Hi, good evening, dear colleagues. You are very welcome to a new Euro webinar in collaboration with the IO Functional, a webinar from the European School of Urology. My name is Salvador Arlandis, and I'm very excited just to start a Euro webinar that will address very interesting and I think that very exciting new field in the computational science, that is artificial intelligence. We'll try to address their applications to functional urology specifically. During the next minutes, I will personally address some basic concepts in artificial intelligence. And afterwards will be the turn of Riccardo Lombardo from Rome, Italy, that will address how to communicate with artificial intelligence, some tips and tricks about how to make the optimal prompts to deal with artificial intelligence. Afterwards, I think that it's very important just to know the real role of artificial intelligence, and for that topic, we have the honor to have with us Glenn Wernburg from Ann Arbor, United States, that will address the applications, the real applications in functional urology. And the last but not least, I think that it's a very important topic just to deal with the ethics and the risks that artificial intelligence we can deal with that problems. My dear friend Tufan Tarcan from Istanbul in Turkey will address this last topic. Not Tufan?
Thank you very much, Salvador, for this very nice introduction. It's my real pleasure to co-chair this webinar with Dr. Salvador Arlandis. And I would like to welcome once again everyone to our webinar. Since our time is limited, I would like to just give the word back to Salvador, and we would love to listen to his talk about the basic concepts of artificial intelligence in functional urology. Salvador, please.
Thank you, Tufan. Well, I have no potential conflicts of interest to report. And first of all, the concept is a growing field of computer science that aims to create machines capable of performing tasks that require human intelligence. That means that these machines or this software needs to have the human cognitive function of perception, reasoning, decision-making, and language translation, for instance. But one more important thing is that the more data the artificial intelligence deal with, and the more it practices, the better it performs. That means that AI learns from experience, and it allows to tackle with very complex problems and in an autonomously way. So it learns from data and examples and improving the performance over time. So instead of explicit programming, algorithms help to AI to learn from experience in different steps, very well defined steps. There is a very wide technology landscape. There are different technologies inside computer science, like deep learning, machine learning, neural networks, or even the most recent natural language processing techniques. And there is many applications on medicine, on social science, on daily life that can get these benefits from artificial intelligence. What applications we can find in medicine in general? Very well-known applications are in diagnosis and early detection, for instance, cancer, cardiovascular diseases, or neurological disorders, and especially applied to analysis of medical images. There is a very important tool in the clinical decision making support, and it helps to suggest differential diagnosis and different treatment options. For sure, for administrative management may be interesting, given many hospitals have different tools to deal with discharge reports and so on. And for sure, artificial intelligence is very important for personalized medicine and genomics, because can identify mutations or design targeted therapies, especially in some pathologies, as we can see later on. What advantages we can find? We can get greater diagnostic accuracy and faster decision making, and can reduce human errors. And for sure, through the telemedicine, improving the performance of telemedicine gives equitable access to healthcare service. And for sure, advances in medical research, making possible to analyze large scale data sets. Some key concepts that could be interesting just to understand the rest of the webinar could be that artificial intelligence is the big set of the different techniques that deal with this objective, just to make the machines be like humans. But machine learning is a subset of artificial intelligence that use large data sets and advanced algorithms to train models that can detect complex patterns. Deep learning is a subset of this machine learning that trains complex neural networks in different layers, just to get more impact in the performance of these artificial intelligence techniques. And the last one would be the generative artificial intelligence that can generate text, codes, images, and so on. And it's very well known by many of the users. Many of you are tools like ChatGPT and so on. But what artificial intelligence needs is information, and especially in form of data sets that are large collection of information that can help the artificial intelligence to learn patterns and make decisions. And if this data set is massive, it's a huge amount of information, we talk about big data that are being managed by these natural language process systems. An algorithm is a very basic tool inside artificial intelligence, that it's a set of rules for solving problems, for performing tasks. It's like following a kitchen recipe, and it can be used for sorting, recommendations, and more. And neural networks are some kind of computational models that are inspired by the brain, with an input and an output, and a hidden layer of different neurons that are sub-programs that can deal with these different signals and can solve complex problems. For instance, this is how works a neural network. When data is fed into a network, each artificial neuron that fires, it's labeled in the slide with the number 1, transmit these signals to certain neurons in the next layer, as you can see, which are likely to fire if multiple signals are received. And the process filters out noise and retains only the most relevant features. So in this way, these neural networks can detect an image that is broken into pixels, and the output will be a dog. So it's capable to recognize different images as dogs and differentiate for different images that are cats or any other figure. Machine learning is a subset of artificial intelligence that is focused on training algorithms to learn from data and make predictions without an explicit programming. And in general, we need to collect the data, gather a lot of examples, and we need to prepare that data, cleaning the data and labeling data. In a subset of machine learning is the supervised machine learning way. And we need to select an algorithm that works better with the objective that we want to use with the data. After applying this model of this algorithm, we need to train this algorithm with new data just to validate the model. And identity and to evaluate just all the steps that we have used to in this machine learning process. As we see, there is different types of machine learning. This is the supervised learning that is trained on label data. For instance, images that are cats, images that are dogs. Unsupervised learning, find patterns in label data is another way of working, of developing this research. And for instance, the reinforcement learning learns by a system of rewards and penalties, just giving a positive result if there is a match with the data that we are looking for, and a negative or a penalty if it doesn't match. Detailed learning uses multi-layer neural networks to recognize these complex patterns in large data sets and are very used in image and speech recognition, autonomous driving, or natural language processing. Because this natural language processing are the ability of the machines to understand, interpret, or generate human language. It's a whole scientific and technological area dedicated to language, with different applications like translation, like sentiment analysis, like chatbots, or summarization of text or email filtering. A subset of this discipline is the large language models they can understand and can generate human-like text, and they can assist different tasks like writing articles, answering questions, and so on. There are many of these different tools that you have used for sure in your daily practice, and we will deal with them afterwards. And this, like ChatGPT, is a kind of generative artificial intelligence. It's when these software applications can generate new content, not only look at the data and give only one output, but can generate new content. This is very important nowadays. And I want to finish my lecture just explaining the different levels of or types of artificial intelligence, from more simple to more complex. More simple probably would be reactive machines that are not they are based only in the current input. They have no memory. They are really fast, but don't learn or remember, and they are very reliable for repetitive tasks. The second level would be those machines with limited memory artificial intelligence. They can acquire the data and have a short-term memory storage. They make a decision making, but afterwards the decision making has been done. They discharge the data or update the data with a new one. The examples would be the chatbots, the self-driving car systems, or virtual voice assistant like Stereo or Alexa. And probably the theory of mind is a very interesting part of the artificial intelligence that gives the ability to understand and model the thoughts, intentions, and emotions of other agents that could be humans or could be even other artificial intelligence. They're very important for social interaction, but nowadays they are still a research field in AI. And at the end, probably the most scaring from my point, part of artificial intelligence is that this artificial intelligence could be conscious of themselves and be able to comprehend its own existence and have sense of identity or be aware of its thoughts and emotions. So would be a special of imitation of the human experience in the world. So in conclusion, I think that AI combines learning high amounts of data, analyzing the data, using algorithms and learning system to simulate human intelligence, and that gives a very important and versatile tool that is invading our lives, and I think that would be an essential tool in the next year. Thank you so much.
Thank you very much, Salvador, for this great comprehensive talk. I mean, it's very clear that we are in the beginning of a big evolution, and we have to be really prepared for this.
Move to Glenn presentations about the real roles and applications of AI in functional urology. So Glenn, the floor is yours.
Thanks very much. Okay, Great. Good to see all of you. Great to be here. We're going to focus on the roles and the applications of AI in functional urology. And here are my disclosures. None are relevant to the talk today, but you can see the humans and the humanoid robots coexisting on the shores of Lake Erie, not far from where I live, in the Michigan and Ohio area in the US. The history of artificial intelligence, I'll cover briefly. Dr. Arlandis gave a wonderful overview, but the term was coined in 1956. 20 years later, it's vastly improving the automatic assembly experience in Japan. Just 20 years after that, it's out competing the reigning chess champion. It's also outperforming many medical experts in interpretation of medical data. And we have to update the slide because only in the past 5 years we have major advances of AI. And we have in 2020, DeepMind developed AlphaFold 2. This has effectively solved the protein folding problem. And I'll show you an application of this and how it's relevant to functional urology. We also have instances where we can use image to or text to image and text to video functionality. Dr. Lombardo is talking to us about prompts like in OpenAI and how ChatGPT can be used to help us with some of our clinical and research questions in functional urology. Now we have instances of physical AI as well, like humanoid robots and some of the robotics that I'll discuss at the end of the talk today. But first, we'll start with the clinical case. This is a 55-year-old female. She's presenting with mixed urinary incontinence. She's had prior unsuccessful trials of oxybutynin and mirabegron. Urodynamics that demonstrates the true seroveractivity and no stress incontinence. She undergoes botulinum toxin intravesical injection. She initially does well, but she develops a post-procedural multi-drug resistant UTI. 4 weeks later, reports that her symptoms following the Botox are 33% improved. She then undergoes sacral neuromodulation, and her stage 1 is successful. She has a 90% improvement on 3-day voiding diary, and stage 2 is then implanted, and she remains dry 6 months following the procedure. So here's the overview of the steps in this individual's case and her medical journey as it reflects her OAB. And we'll start with the oxybutynin and mirabegron, her trial of medical therapy for her OAB. This is unsuccessful. It's an opportunity for improvement with AI. And we're going to take a step back and look at how AI can help us with novel drug agent development. So this is the structure of the beta-3 receptor bound with mirabegron. Mirabegron is shown in yellow here, and the remainder of the ribbon diagram is the beta-3 receptor. This was solved by Nigiri et al. To near atomic resolution back in 2021. You'd imagine, like many of these protein structures, crystal structures, and EM structures, this took many years, decades worth of work and millions of dollars to do this. But all of this is changing now with the advent of AI. Because as I had mentioned, you can now plug in the amino acid sequence of a protein and very rapidly have the protein structure with a high degree of accuracy. And that's exactly what I've done here. I plugged in the amino acid sequence of the beta-3 receptor, and this is the ribbon structure. So all I'm going to do between this slide and the next slide is reorient this molecule and recolor it. And you can see, for all intents and purposes, it's identical to the structure that was solved empirically by Nigiri et al. So the empirically solved structure is on the left, and the AI solved structure in 5 minutes is on the right. They are essentially the same. Can take it a step further. We can use another program and we can dock molecules onto the structure. So again, virtually we have an identical AI solution structure to the empirically solved structure of the beta-3 receptor with mirabegron bound. So this is great. We can replicate what's already been done, but what's the true application here? Well, the application is this. We can take it one step further. Here's our mirabegron. Here's our molecule that we've screened, or we know that it binds a receptor with high affinity. You can use an AI-based program to generate a large library of similar but not identical molecules, such as the 12 shown here. You can do the same thing for tens of thousands of different molecules, each iteratively different from the last, and you can screen the molecules of this library virtually for their binding capacity to a protein of interest, like such. So here is the space-filling model of the beta-3 receptor, the same one I've shown you, and this is the binding of mirabegron to that receptor. So you see the stick diagram of mirabegron, you can see the ionic and hydrophobic, hydrophilic interactions with the amino acid side chains of the beta-3 receptor with the molecule mirabegron. You could do the same thing with any of those other molecules we've identified from our library, like this one here, SC4465, etc., and you can see similar interactions here. The key, and what I wanted to demonstrate to you here, is that this molecule we identified from this library binds to that receptor at an even higher affinity than that of mirabegron. So this screening compound, 4465, etc., has even more negative kilocalories per mole, the calculated affinity, than that of the interaction with mirabegron. So a stronger binding affinity. Doing studies like this and virtually analyzing interactions like this could lead us to the next begron or the next drug class of molecules. So there's a lot of opportunity here. AI is helping us drive it forward. It's expediting the drug discovery pipeline on the order of decades. This patient, as I mentioned, she undergoes urodynamics. This demonstrates detrusor overactivity. This is interpreted by the clinician. One very real possibility of using AI is to automate the interpretation of urodynamics. We already have many instances wherein this is happening, like in Screen Right. Wang et al. Have shown very nicely that they can accurately classify a detrusor overactivity event versus a non-detrusor overactivity event with a high degree of accuracy. But can we take it a step further? Can we take a step further like they're doing already in cardiology? For example, Attia et al. Have demonstrated an AI-based algorithm to predict atrial fibrillation from only normal EKGs. So they took over 600,000 normal EKGs, and from these normal EKGs, they can accurately identify who had an underlying diagnosis of atrial fibrillation, even though that wasn't captured on the EKG itself. They developed this algorithm that appreciates novel patterns that were not appreciable by humans. So can we do the same thing with urodynamics to help us better understand the pathophysiology of some of our functional conditions? I'm very optimistic that this will be the case. The idea is to identify complex patterns that humans are not yet able to recognize to better understand the best diagnosis and the best treatment for a given individual, and to better understand the pathophysiology of the disease. The patient went on to get botulinum toxin. We know, by the way, botulinum toxin, sacral neuromodulation, both very effective therapies and similarly effective therapies for overactive bladder, but a subset of patients don't respond to either of these therapies. This particular patient did not respond to botulinum toxin, but the idea is, can we very accurately predict who would respond versus not respond to a given treatment? And this could be advanced therapy for overactive bladder. It could be outlet therapy for benign prostatic hyperplasia, or any other therapy for a functional urology condition. We were interested in using overactive bladder first. So we trained a series of algorithms on the Rosetta trial. This is one randomized controlled clinical trial data set. And we validated them on another randomized controlled clinical trial data set. And these two data sets were quite different. You can see some of the highlights here. The idea was to take two heterogeneous cohorts different from one another. If the algorithm would perform well in this simulated scenario, it would be likely it would be able to perform well in the real world, where data and patients are not homogeneous. So we developed our algorithms. This is just some visualization demonstrating our algorithm shown in green and how it can much more rapidly and accurately approximate a true function shown in black when it's trained only with the training data shown in black dots. So you can see our algorithm in green more accurately and rapidly approximates the true function than the best next available algorithm, which is shown here in red. It gets to the function, or gets close to the function eventually, but it's much slower, and ultimately it's less accurate. So we developed this underlying math. It's an analog of what's called operator splitting. It comes from optimization theory. And using this, we can accurately predict who responds versus does not respond to treatment. We did the same thing with botulinum toxin and with sacral neuromodulation. Here's an example. Our neural network, shown in green, and outperforms the standard statistical approaches as well as other AI-based algorithms. And it also outperforms 4 human experts that were tasked to make the same prediction. And you can see on screen right there, we're developing graphical interfaces that can help us better counsel patients. For example, Ms. Smith, 19 out of 20 individuals with personal factors similar to yours will experience clinical response to sacral neuromodulation or to botulinum toxin. And we're finding that having these graphical interfaces with the underlying algorithms that can accurately predict a response are helping with patient counseling. The patient developed a urinary tract infection. This particular urinary tract infection had multiple resistances to the antibiotics. The idea of antibiotic resistance is it's the evolution of bacteria to survive antibiotics that are designed to kill them. It's a global problem. There are over 5 million deaths per year, and resistance is amongst the top 3 greatest threats to humanity today, the World Health Organization tells us. And misuse and overuse of antimicrobials are the main drivers of drug resistance. The issue in urology, and it's even more so in many other medical fields, that the urine culture takes 72 hours for its antibiotic sensitivity results to result oftentimes. In orthopedics or in bacteremia for blood cultures, often it takes even longer for those cultures. And during this window, empiric antibiotics are often prescribed. And we know that about 30% of that empiric therapy requires modification based on the final culture results. So what we wanted to do is very accurately predict the sensitivity and resistance to a series of antibiotics at day 0, at the time when a UTI is suspected, rather than in day 3 when the culture results finally come back. So we wanted to predict culture sensitivity. We trained a series of algorithms on 4 million antibiotic sensitivity resistance classifications here, and we tested them internally and validated them externally on a geographically distant hospital cohort of patients. And again, the predictions were 3 days prior to the sensitivity availability, essentially at day 0 before any culture data were back. And we developed models for the 11 of the most commonly and clinically relevant antibiotics, and we developed a user-friendly embodiment. And some of our representative results are shown here. You can see 11 of the different antibiotics that we looked at. The areas under the curve were strong. There's a high degree of accuracy for making these predictions on column, the leftmost numerical column. This is the area under the curve without any organism information. Typically, the AUCs were 0.8 and greater. Once the organism became known, these iteratively improved, oftentimes 0.9 and greater. And then the rightmost two columns that are numerical here, we validated our algorithms externally on a geographically distant hospital cohort. You can see they hold up in terms of accuracy. And then when we applied that geographically distant hospital cohort's antibiogram to the training data, they further improved iteratively. We're developing graphical interfaces to support these algorithms as well. You can imagine we can incorporate things like patient allergies and drug-drug interactions to help provide the best information for the clinician to optimize antibiotic therapy. We're also working to improve the underlying math for these algorithms. We're taking those results as a benchmark and applying quantum computing to see whether quantum computing can outperform our algorithms. In theory, quantum computing may be able to arrive at the answer more rapidly, more accurately, or require less training data. The fundamental computing unit for classical computing is the bit, 0 or 1, essentially this or that. But the qubit is 0 or 1 or anything in between 0 and 1, or all of the above simultaneously. So in theory, it can more accurately, more rapidly predict an occurrence such as antibiotic resistance. Finally, this patient undergoes sacral neuromodulation. She's successful with that. As we know, the voiding diary is an important parameter prior to sacral neuromodulation and to assess the outcome of sacral neuromodulation and other therapies like Botox and medical therapy as well. We also know that this can be challenging both for the clinician and the patient. So here's an example of how Wangbo et al. Automated the bladder diary using AI-based technology. So what they've done is they've developed a smartwatch program that monitors the postures, the movements of the patient, and from this, they can very accurately classify the duration and the number of voids over a 1 or 3 day bladder diary. So they're showing here that they can very accurately make those predictions of how frequent and how long those voids occur. So this is an exciting opportunity to automate one of the more challenging diagnostic aspects that we see in functional urology. So here's our clinical case once again, and for each of these items of the case, we've discussed an AI application. Some of these are happening now, some of them are in the pipeline, and this pipeline is going to come to fruition in the next months and years. Before I wrap up here, I just want to discuss a little bit about some of the physical AI developments that are occurring currently. These are some of the exciting aspects of how AI can help drive physical design of some of the devices that we use in functional urology. For example, a catheter. This group is Zhou et al. Out of Caltech in California. They demonstrated that a design that was generated using AI can reduce the retrograde propagation of bacteria from the outside environment into the human bladder via catheter. So it prevents retrograde propagation, retrograde migration of E. coli, but not the antegrade flow of E. coli with urine. And on the bottom right there, they're showing that their AI-designed catheter reduces that retrograde migration relative to a smooth catheter. This is an exciting opportunity for the future, and it underscores the importance of collaboration. So here, there were AI scientists involved, there were microbiologists, material scientists, and other specialists as well. As we know, our robotic systems are already capturing movements in the X, Y, Z coordinates as a function of time, and it's just a matter of time before we can implement AI to improve the automation of robotics. We're already seeing that this can be done on the benchtop with a gallbladder removal, for example. I think we're getting very close in developing the training data sets necessary to allow for the automation of some of our robotic and non-robotic approaches to surgery. This is an opportunity to improve the access to care around the world, including in resource-limited populations. So in conclusion here, AI has the capacity to improve many aspects of clinical care and workflow efficiency, the identification of fundamental problems in functional urology, and collaboration is necessary. So collaborations such as these, wherein we meet from around the world and talk about some of these applications, as well as interinstitutional databases, collaborations between clinicians, basic scientists, engineers. But at the end of the day, patient care needs to remain the focus. So thank you all for your time today. I'm excited to take some questions at the end.
Glenn, thank you very much for this very nice talk, as always. And thanks for sharing with us almost all the promising fields where AI technology can be implanted or already has been implanted. Now we are going to continue with Dr. Ricardo Lombardo, who is going to talk about how to communicate with AI. What are the tips and secrets? Ricardo, please.
Thank you very much. Thank you for this opportunity. It's a very great pleasure for me to present this nice presentation. So I will start with this quote. So AI is not magic. So it's just our collaborator, but you know how to talk to it. So because I wanted to do a practical session, I will show you how to communicate, especially with natural language models, which are probably what you use in everyday clinical practice and in life, actually. So, what is a prompt? Actually, a prompt is a little different to what we really do. So normally, we will give some instructions. We have sometimes prompts and good prompts. So the main difference is the fact that a prompt is not exactly a question that you do on Google. So a prompt is more AI. Who is would he answer? What is ask? what you want out of the text, your presentation, and public talking to a real person. That's what you actually should think about it. So we have four big blocks to talk about. So what is the role of the AI? So you could tell to the AI to act as a medical researcher, to be a marketing consultant, or a university professor. So you have to say the tone, what is exactly what you want the AI to do. The second thing is the task. So what you exactly want. I got examples. So for example, instead of saying explain physics, we should say to the AI, explain physics to a non-technical audience in simple language. So the better the prompt, the better the answer we will get. The third thing is the context. Are we talking to medical person, to non-medical, to people who have an instruction or not? It's very important. So because it's a practical session, I will try to give you some tips on how to write a prompt, actually. So as you can see here, there is a weak prompt on the top and a strong prompt. So it depends on how much information you give to your AI. So what are the tips? The tips are, first of all, ask for a reasoning style. So you have to explain step by step what you want the AI to do. You have to iterate and don't restart. So you have to follow. So it's like talking to a person. You have to not to re-explain. So it has memory. And the other important thing is also say what you don't want the AI to do. So that's another very important thing. Common mistakes, it's being too vague, not to specify the audience, asking everything together. So this is a very good. I have some practical important things applied to actually to the functional urology. So we have an example of a weak prompt, explain the truth of activity, of a strong prompt. So you are a functional urologist, as we said before. Explain the truth of activity to a urologist resident. And what is the focus on? Pathophysiology, typical urodynamics findings, and clinical results. And to keep it under a certain words. So let's see an example of a weak prompt. So we ask, I get the example of ChatGPT, explaining the truth of activity. As you see, it goes very wide. So we have a lot of information. So pathophysiology, management, but it's very vague. It's not very, I mean, for someone finding something more specific, it's not very important. It's too vague. So we don't give enough information. We get a vague answer. So my comment is it's generic. It's textbook style, no clinical focus, and it's not useful in clinical practice. What happens if we give the good prompt? As you see, we have an answer which is under 150 words. We can have a very good and concise answer for a urology resident. So we said the same question with a different explanation. So the result is structured, clinically oriented, and immediately usable. Last thing is some functions that I want you to know. So if you use GPT, you can create a project. This project is Functional Urology Expert. So you have a specific chat. You can find it in some of the versions of GPT. And we can always give it the prompt, but now the prompt will be actually in the project. And we get, for example, another question, what is bladder capacity? And we get a good definition for a resident. So this is one of the functions. The second function I want you to show is the one on creating your own GPT. So this is a more advanced stuff, but it's easier. It's easy to actually to perform for anyone. So we did the same explanation, but we get an app which is Functionally Urology Mentor, we will call it. So he asked us if we like the image. I actually didn't like it, so I asked it to change it to a different image for a more modern, different. And then you have the configuration part when you have all the instructions, and the final result is that you get your actually own GPT app, which will actually answer to all the questions on functional urology. You can also upload some documents. And I think this is a very nice thing to know, because it is a practical course. It's something that you can bring home and you can actually apply right away after this course. So the prompt actually is kept by your app. So now this app is only for the app. So as you can see on the left, I have developed different apps with different purposes. I think this is something very useful, and you can actually apply it to all kind of urology subjects. So my conclusion is that AI always reflects what we put in. So the most specify we are, and the best we get from the AI, we have to actually define the role, the task, and the context. It's very important to give how it should reason, and iteration is part of the method. So we have to follow and actually correct sometimes the outputs it gives. It's an assistant, it's not an authority, so we have to give him the right importance. So effective prompting transform AI from a generic tool into a domain-specific collaborator. This is my main conclusion, and I hope this will give you some tools to improve your usage of AI.
Thank you, Ricardo. It has been a very excellent review of the different prompts. How can you use the prompts to be effective to get the good results? And just the last but not least is just one problem that we can address is the different ethical concerns in AI. Please, Tufan, can you guide us about this?
Thank you very much,
really
Salvador. I hope
tricky part.
I may be, I may be guiding you. It's a very complicated subject indeed.
Yeah,
So I will do my best.
in fact, there is some questions about in the audience about some ethical concerns. So
Yeah.
I hope that you can answer
Yeah.
our audience.
So I will be talking about the ethical concerns in AI, about the privacy of the patients, risks that are awaiting us, the bias, and the legal responsibilities. These were my disclosures, and nothing is directly related to my talk today. So we have seen, I mean, we have listened to great three talks. We have seen that AI is already there, as for example, automated urodynamics, and as for example, diagnostic tools in different types of avoiding dysfunction, and in the management of OAB, for example. And also I can add to what we have discussed, for example, risk stratification for upper urinary tract deterioration in neurogenic patients. These were all examples of the implantation of AI in functional urology. So these were, of course, the good parts, but what may be the risks? Just I want to add to these examples, the most common utilization today is maybe, although it's not written in the literature, is related to the writing discharge summaries. I'm hearing this from my colleagues very frequently. They say, oh, the AI is better than my resident to write the discharge summaries. So this is also an open area to discuss for us. How reliable are these reports, and what's going to happen if a mistake is there made by AI during these discharge summaries, which we cannot recognize when we sign these reports. So our functional urology data is sensitive because we are dealing with quite personal things such as incontinence and sexual function. And although we are trying to hide these data with anonymized data sets, the technology says they are not completely secure because these data sets can often be re-identified when combined with other metadata. And for example, a location data from a smart bladder diary application. So the privacy is a really an issue. And if somebody wants, there are different ways actually to access the private data. This is especially true for home monitoring applications such as audio uroflowmetry or cloud storage of patient-reported outcomes. So the privacy of the data is an issue for us. Another issue is the algorithmic bias we get from the AI, what we depending on the data we provide the AI with. So if I mean the AI analyzes the data that is available, and the data is not good, the result of the AI commentary will also not good in parallel to the existing data. So what do I mean? For example, an algorithm that is based on the data sets coming from large academic centers may not represent the real life data. So we have to we have to make the AI meet with the real life evidence, and the data coming from academic centers may not represent the real life data. And also, we have to categorize the patient groups very carefully. The neurogenic patient groups, for example, may differ from each other depending on the underlying neurogenic disease, and one group may not be representing the other group, but the AI can miss that. So we have again to be careful in the representing patient groups when we get the suggestion of an AI. Another bias can be related to racial differences or socioeconomic differences. All the points, actually, as physicians, that are we are not very well, let's say, knowledgeable about these facts, but this may affect the AI performance. So the accuracy of the data is, of course, important, and plus the AI must also be accurate in analyzing the data. One problem here is called as the black box problem, which means you cannot negotiate or discuss with AI about its suggestion or its final diagnosis or finding. So therefore, it is called black box, and you cannot find out the errors of AI possibly made. These may be an artifact, for example. Another problem that is discussed is the so-called automation bias. Some physicians may tend to trust the machine over their own judgment, especially when they are fatigued. So we may also need to talk about the so-called hallucinations. Hallucinations mean the wrong data that we get from AI. And unfortunately, it can happen. And Ricardo has very nicely indicated that it is important to find the correct question or to ask the correct question to AI to get the correct answer, which is not always easy. And the AI, unfortunately, can generate you data based on wrong citations, or they can, unfortunately, also create citations. These are called hallucinations of the AI. Now, I think we are now in a gray zone because we are in the very beginning of a new evolution, and we have to be very careful, especially during the gray zone. For example, if you sign off an AI-interpreted urodynamic report that misses a high-pressure bladder, Now, who is reliable for this mistake? Unfortunately, still the physician is responsible who signs the report, not the software developer. But now we may face a new legal danger here. Just think the opposite. If the AI becomes the standard of care, and if the physician ignores the decision of the AI, but which turned out to be right, then the physician is still responsible because he or she did not respect the decision of the AI. So, I mean, all these issues also, of course, contain legal issues, and also we need regulations there. Unfortunately, they are missing. How are we going to protect ourselves? So, before adapting a new AI tool to any clinical field, there are certain questions that we have to ask and get the assuring answers. Patients or not? The other important point is the explainability. Does the tool highlight the artifact or wave it is analyzing, or just give a score? This again is related to this black box issue that I tried to explain. And the transparency is important. Inform our patients that AI is assisting us. And there is certain a role of human, as we call as human in the loop. And we have to review all the possible data set before finalizing the report. But then if we are going to do that, what will be the benefit of AI? So there are still these controversies that we have to solve. For example, we can think of a case here. This may be a 45-year-old male with complex lower urinary tract symptoms, and the patient is advised to fill in a bladder diary application that tracks fluid intake and suggests behavioral modifications. And the application interprets the high frequency of this patient as overactive bladder and suggests fluid restriction to the patient. But however, somehow it misses the underlying nocturnal polyuria and the borderline renal failure. And as a consequence, unfortunately, the patient then presents with acute kidney injury from dehydration. So, is the physician responsible who prescribed the application to the patient or not? This is a simple example. I hope we are not going to face these problems in the future. We can, of course, mitigate this practice and reach a best practice if we treat AI as a second opinion, but not the truth. At least for today, where we are in the gray zone. So we also should demand from the AI explainability. We need to choose tools that show their work. For example, if an AI analyzes the urodynamic trace, we need to be able how AI does it, and if the AI has found any artifacts, for example, these artifacts must be shown on the result of the AI as well. And of course, patient groups may be different, and the AI should be validated on our specific patient demographic. And we have to inform again our patients when AI being used to process their sensitive data. We have to inform our patients. I use an AI tool to help to analyze your test. I personally review every single line. Of course, this is the optimal way to do it. But again, I mean, if we are going to analyze the AI to protect ourselves, then the AI utilization may not be as practical as we wish. Until, I mean, the urologist is still the doctor who decides, and the algorithm is the tool. I think we have to be very careful with the regulations and with our legal responsibilities before implanting the AI so quickly in our profession of urology, and especially functional urology. Thank you very much for your attention.
Thank you so much, Stefan. I think that has been an excellent lecture of dealing with all of these ethical problems. That I think that some of questions from the audience are dealing with these ethical problems, and some of them I think that you have already answered to them. But from my point, I think that not everything is clear. I think that some issues still remain, and in the future, we need some kind of white book explaining the ethicals and the limits and the dangers that we can find using the AI in our daily practice. For instance, there is some question that comes from, Michael Van Valken asks us, the positives are clear, but when AI is being used in healthcare, who is responsible for the outcome in case a diagnosis advice proves not true or working? Who would you state is responsible? The doctor, the AI company? Well, I think that you have answered partially, but still remains a problem,
Yeah.
not?
Yeah, today, as of today, Salvador, the physician is responsible for everything. And
Yeah.
AI is only the tool that we are using. So therefore, so we should never forget that. And we cannot protect ourselves by saying, okay, this AI has told me to do this, and then this bad result happened. It is not my responsibility. Unfortunately, it is not
No.
the case. So we are the ones who are responsible, not the software engineers or the company who develops the AI.
For sure. I think that this is a very important message that had to be very clear for the audience. And there is a second question from Joseph Marenkak that says, how should a urologist respond if an AI-based decision support tool recommends a management option for a patient with, for instance, neurogenic lower urinary tract dysfunction that conflicts with both guidelines and their own clinical judgment?
I think we may better ask this to Glenn and Ricardo Salvador if they can join us here, if they are
Yeah,
in
they
AI.
are
Just get
just
their opinion. Yeah.
sure. It's an ethical question, but
Yeah.
again, it's when there is a conflict about even if the prompt is well done, but you have a different opinion. What's your position in this case?
Well, the position is clear, and it's exactly as Tufan said. At the end, it's the clinician. So just like any tool, any information that we use, we don't follow it blindly. If we see a radiological study and the person who officially interpreted it did not see a stone, but there's a stone there, we still need to consider the stone. So if we have a patient that we believe is at high risk for upper tract deterioration, but the algorithm does not pick it up, well, clearly we would need to still work up that patient as a high risk person. I think it makes sense to try to understand why perhaps the algorithm reached a different conclusion, but at the end we need to only incorporate this as just a tool in our toolbox and use it to make our clinical decision and override it when we need to. We should not be afraid to do that.
Ricardo, do you
Yes.
agree with that point?
Well, I completely agree, but I think that using specific tools will lower this risk because the more we train the tools, the better we get it. So I don't think this will come slowly, but we cannot use the overall tool for every task. So I think this is essential that this message passes. We need specific tools, even if it's GPT or whatever, for specific tasks. I think this is the message to bring to the audience.
Very interesting. But don't you think that for sure supervising the answer while the output of the system is really easy for expert people? But what happens when you are asking for a topic that you are not really expert, but you need assistance from that? I think that it's one point of the risk that you are in the clinics, you are not an urologist, for instance, and you need just to make a question, very specific question, and you rely on the experience of their AI because you don't have a colleague in the office at your side. So
I think it's very risky. It's like
yeah,
operating someone just based on a report and not watching the images. It's something that you never do. The one time you do it, you get the wrong side. Be for sure that's the point. I mean, you cannot rely on for the moment on that. You can rely on simple things. You can. It's a good as I said, it's a good assistant. You cannot ask for more for the moment. But in any task, it has never reached 100%. So if once it reaches 100%, that it's okay. But I don't think it's reliable nowadays. I mean, I would ask several times or different ones. That might be an option to reduce the risk. I will ask, you have different AIs, so try the same question to different AIs. That would be a practical point, I think. No, that
okay.
might be, but
It,
or
it
find a colleague, it's better because
yeah,
if he
yeah.
gives you the wrong answer, at least you can call him after. You
Sure.
can be mad at him.
Sure. So I think there is one last question about, it's very interesting. I think that Glenn, you are the right person to answer this question. Can AI replace human in scientific research? It's a very big question. In the future,
Well,
I don't know. I don't
yeah,
know
well,
now.
certainly now the answer is no. As I demonstrated, AI can help expedite some of the research in, I think, very meaningful ways. Um, for now, absolutely, humans are still asking the important questions. AI is helping us and perhaps exploring some of the important questions and testing hypotheses. But in the future, it's difficult to predict.
Yeah,
Things will evolve, and the answer 1 and 5 years later is going to be different from 20 years later.
yeah, sure. Well, there is one question that it's so about the manipulation of input data in order to prove some theory that may be not be true at all. So there is some people that are concerned about this possibility, just to train wrongly some algorithms to get some biased questions. It could be part of the ethical problems designing an AI and a specific AI.
Yeah. Salvador, can I just comment on this question? I find
Yeah,
it very important. I mean, this is a very, very important question. It is good to be prepared to prevent this. So, I mean, we have a long way to go in terms of regulations and legal controls here, really. It's more complicated than we think, I guess. So these are all the points that we have to be very careful. This is possible. This may be really done. So I mean, we have to prevent it. I don't know how, but this is a very complicated issue.
okay. So we think there is no more questions now from the audience. I think we are just on time, just to conclude our webinar from the European School of Urology in collaboration with the functional section of the EAU. And just to thank all the panelists and for your participation, and especially from the audience that it's in the other side, online connected to us, and for sure some of you can connect and see offline this webinar that we hope that could be very interesting for you and explain some questions. Yes, the voice is yours now.
Well, thank you very much to you, to our speakers, to the EAU, to the technical support. I wish
Sure.
everybody happy holidays and a great new year.